My name is Lauralyn McIntyre, and I was the principal investigator on the fluid trial. Monica Taljaard was my co-principal investigator, and she is the lead methodologist on the fluid trial. On behalf of all the fluid trial co-investigators, Monica and I will present the protocol and results of the fluid trial. So the fluid study question is, does a hospital policy or strategy of a predominantly universal supply of Ringer's lactate as compared to normal saline reduce death or readmission to hospital within 90 days of the index hospital admission? Hospitals in fluid were randomized to fluid A versus fluid B. The first study period was for 12 weeks, after which the hospital was crossed over to the other study fluid for 12 weeks. For study periods 1 and 2, hospitals stocked the study fluid, after which there was a 1-week run-in prior to accruing patients, followed by a 2-week run-out period. In fluid, there was no individual patient data collection. All data in fluid was obtained through ICES, a provincial health database in the province of Ontario. The primary outcome in fluid was a composite of death or readmission to hospital within 90 days of the index hospital admission. Secondary outcomes included death and readmission to hospital within 90 days of the index admission described individually, initiation of dialysis within 90 days of the index hospital admission, index emergency department visits within 90 days of the index hospital admission, and discharge to a facility other than home. Now I'm going to hand over to Monica Taljaard, our lead fluid methodologist, to take you through the methods of analysis for fluid.
Thank you, Lauralyn. So first, I'm going to describe the sample size calculation for the fluid trial. So as you may know, cluster randomized crossover trials are more complex to design because you need estimates for 2 ICC parameters in advance of your trial. First, you need an estimate of the within-period intracluster correlation coefficient. That is the correlation between 2 individuals in the same hospital and same period. And second, you need an estimate of the between-period intracluster correlation coefficient. That is the correlation between 2 individuals in the same hospital but in different periods. One would generally expect the strength of the correlation between 2 individuals in the same hospital to weaken the further apart they are in time. The cluster order correlation coefficient, or CAC, is just the ratio of the between-period ICC and the within-period ICC. So it measures the degree of decay in the strength of the correlation over time. In the fluid trial, we were able to access historical primary outcome data, that's numerator and denominator data, for all eligible hospitals and all patients across Ontario on a monthly basis through ICES. And this allowed us to estimate these sample size parameters very reliably. Specifically, we estimated a within-period ICC of about 0.006 and a CAC of 0.95. We also assumed an average of 1,500 patients per hospital per month once we eliminated hospitals with fewer than 6,000 annual admissions. We wanted to detect a very small absolute difference of 1% between the normal saline and Ringer's lactate conditions, which we argued was important at a population level. Our calculations show that we needed only 6 hospitals to reach 80% power with a 5% level of significance. However, trials with a small number of clusters are not desirable for various reasons, and therefore we applied some adjustments to increase our target number of hospitals. Specifically, we allowed for 6% non-adherence in the normal saline condition and 19% non-adherence in the Ringer's lactate condition. This was based on results from the pilot trial. We also added 2 clusters as a small sample correction, that is to account for the fact that the sample size formula is based on the normal approximation. And then we added 2 more clusters to account for cluster size variation, which tends to decrease power a little in a cluster crossover design, which brought us to a target of 16 hospitals. Next, I want to describe our statistical analysis methods. In Fluid, the study question was defined at the level of the hospital. So rather than studying individual fluid exposure, we were interested in whether a hospital policy of a universal supply of Ringer's lactate compared to normal saline reduces the composite outcome of death or readmission to hospital within 90 days. Therefore, we specified our target estimand as the hospital averaged effect, and we analyzed our data not at the individual level, but at the hospital level. So we used an unweighted linear regression analysis of hospital level proportions. The 2 main advantages of using a cluster level analysis are that this method is robust across a wide range of scenarios, including when the number of clusters is small, even as small as 4 clusters in some studies. And secondly, it readily yields an estimate on the absolute risk difference or risk ratio scale without the convergence problems we tend to see in individual level methods. On the other hand, disadvantages are that it can be less powerful than individual level methods when cluster sizes vary, and covariate adjustment is a little bit more cumbersome, requiring a 2-stage approach. In the Fluid trial, our pre-specified covariates were age, sex, type of admission, comorbidity index, and ICU admission within 1 day after hospital admission. The 2-stage approach required us to first run a logistic regression model of the patient-level data, ignoring the treatment and cluster indicators, but including all the patient-level covariates. This model was then used to obtain residuals, in other words, observed minus predicted number of events for each cluster period. In stage 2, these residuals, rather than the observed proportions, were then analyzed as dependent variable in a simple linear regression analysis with indicators for treatment, period, and cluster. Our initial analyses treated period as a binary indicator, so ignoring the fact that in Fluid we used sequential randomization. Of course, this would not adequately control for seasonal variation, and thus we conducted 2 additional analyses in which we analyzed calendar time as a continuous variable. So in our first sensitivity analysis, we analyzed it as a simple linear term. In our second sensitivity analysis, we analyzed it using a restricted cubic spline. It was very reassuring ultimately that results were virtually identical across different methods. Our subgroup analyses were conducted similarly, but without covariate adjustment and using stratification. We also conducted sensitivity analyses excluding some populations. Now I want to hand back to Lauralyn for the presentation of the Fluid trial results.
The Fluid trial began recruiting in August 2016 and completed recruitment in March 2020. A total of 7 hospitals participated for a total of 43,626 patients. There were 22,017 patients in the Ringer's lactate group and 21,609 patients in the normal saline group. We were unable to attain the originally planned sample size of 16 hospitals due to the onset of the COVID pandemic, which made this hospital-wide trial completely infeasible. Data was 100% complete for the primary composite outcome and all of the secondary outcomes. The baseline characteristics in Fluid were similar between the 2 fluid groups for age, sex, place of residence, and income quintiles. The baseline characteristics were also similar for case mix group, the Elix-Hauser Comorbidity Index score, and the Elix-Hauser Comorbidity Index score divided into quartiles. The overall adherence in the normal saline group was 93.6%, with a range from 91.7 to 98%, and for the Ringer's lactate group it was 78.2%, with a range from 70.5% to 89.9%. The total volume of normal saline and Ringer's lactate combined in fluid was 330,542 liters. In terms of the primary composite outcome of death or requirement for readmission to hospital within 90 days of the index admission, it was a mean of 20.3% versus 21.4% in the Ringer's lactate and normal saline groups, respectively. However, when the linear regression analysis of cluster-level summary data was adjusted for age, sex, case mix group, Elix-Hauser Comorbidity Index score, and ICU admission within 1 day after hospital admission, and accounting for period effect and clustering by hospital, the adjusted mean difference was 0.53%, favoring Ringer's lactate, but also with wide confidence intervals crossing the null. There were also no other detectable differences for Ringer's lactate as compared to normal saline or any of the secondary outcome measures. We also performed a number of pre-specified subgroup analyses according to groups that may have received a large volume of IV study fluid and/or that were increased risk for death or adverse outcomes. These analyses represent cluster-level averages accounting for period, intervention, and clustering by hospital, but without covariate adjustment. Subgroups included sex, age, case mix group, Elix-Hauser quartiles, ICU admission within 1 day of hospital admission, and type of surgery. There were no signals for benefit or harm for Ringer's lactate compared to normal saline, except for patients who were more than 80 years of age, where in this group there appeared to be benefit for Ringer's lactate. However, these results should only be considered hypothesis generating and be considered for further research. We conducted additional subgroup analyses for patients with infection, sepsis, defined by the combination of infection plus organ dysfunction, trauma with an injury severity score of at least 12, and traumatic brain injury, with and without admission to ICU within 2 days of hospital admission, with no suggestions for benefit or harm for Ringer's lactate compared to normal saline for any of them. We also conducted a number of pre-specified sensitivity analyses on the primary composite outcome to examine the robustness of our study findings. These analyses also represent cluster-level summary data adjusted for age, sex, case mix group, Elix-Hauser Comorbidity Index, and ICU admission within 1 day after admission to hospital, and account for a binary period effect and clustering by hospital. These analyses included removal of elective surgical patients who were discharged within 1 day after the index admission, mental health case mix group, vaginal and C-section deliveries, and patients that could have been exposed to both study fluids, defined by patients admitted during period 1 and discharged during or after period 2, at admissions during period 2 and discharged after the period 2 runout. In addition, we ran 2 additional models to examine for potential period effects. None of these sensitivity analyses modified the estimates of the treatment effect for the primary composite outcome. Fluid did have several limitations. The trial was stopped early due to the COVID pandemic, so we did not reach our sample size of 16 hospitals. Adherence to Ringer's lactate was lower than normal saline. Health administrative data may be less accurate as compared to data collection performed by research coordinators. However, these misclassifications would have been non-differential. Complex logistics necessitated sequential site enrollment, so fluid was vulnerable to time-confounding seasonal effects. However, secondary analyses adjusting for calendar time were consistent with the main trial findings. In conclusion, fluid findings align with recent meta-analyses of randomized controlled trials in the critically ill, which suggest small but clinically relevant reductions in death favoring balanced crystalloid fluid. Although the adjusted absolute difference of 0.5% in favor of Ringer's lactate was small, these differences could have a major effect at the level of the hospital and healthcare system. Monica and I have so many people to acknowledge. First is our executive committee, which is composed of clinical trialists, ethicists, large database experts, and knowledge implementation experts. And with specific thanks to Tracy McCardle, who is the Fluid Trial Research Manager. We would also like to thank our site lead investigators and research coordinators, logistical services personnel, nurse managers, and educators at each of our sites, ICES, administration, patient partners, the Canadian Critical Care Trials Group that nurtured this research program along from its inception, and our funders, the Canadian Institutes of Health Research and the Ottawa Hospital Academic Medical Organization.